left my favorite shirt in the dryer of your apartment. Left a handful of hurt right here in my pocket at a favorite coffee shop in the early morning sunlight. We don't need to talk, we both know it's alright. When I don't know the song, will you help me find it? When I need someone, you know I wouldn't mind if you held your body close to mine for a little while. The ice cream truck rang its bell. We ran out just in time to sit there on the front porch. You with yours, me with mine. The sunlight on the water, the birds above in flight. We ain't doing what we oughta. We both know it's alright. When I don't know the song, will you help me find it? When I need someone, you know I wouldn't mind if you held your body close to mine for a little while. 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 For a little while.
Good morning, everyone, and a very warm welcome to E for Endometriosis second quarterly Zoom session for 2026. My name is Radhika and I will be your MC for today's session. A little introduction about myself. I am a researcher and I'm hoping to do my PhD on understanding the neurodivergent experience of endometriosis to better understand the comorbidity and to promote more inclusive and accessible care. In terms of my personal journey, I recall having unbearable period pain for almost all of my life and other endometriosis-related symptoms, including increasing pelvic pain outside of my periods. But I was always dismissed in clinical settings and by those around me. Right now, I am still seeking answers and I don't have a diagnosis yet, but I am receiving support for suspected endometriosis. Some symptoms do persist, of course, but medication has still been helpful. I am part of the E for Endometriosis community, and it is my privilege to be here today to help hold this space for learning, awareness, and meaningful conversation. Thank you for taking time out of your Saturday to join us. Whether you are here as a patient, caregiver, healthcare professional, ally, volunteer, or someone who simply wishes to understand endometriosis better, we are truly grateful to have you with us. So today's topic is endometriosis and its comorbidities, understanding commonly coexisting conditions and their impact. Endometriosis rarely exists in isolation. Many individuals experience additional coexisting conditions that affect multiple body symptoms. These can complicate symptoms, delay diagnosis, affect treatment decisions, and impact long-term care. Today's session will explore commonly coexisting conditions associated with endometriosis and how they may contribute to chronic pain, fatigue, and reduced quality of life. We hope this session will help everyone gain a clearer understanding of why symptoms may extend beyond the pelvis, why pain can persist despite treatment, and why a more integrated whole person approach to care is often needed. So about E for endometriosis, for those who are new to us, E for endometriosis is a ground-up movement dedicated to awareness, education, and community support for those affected by endometriosis. Our quarterly Zoom sessions are part of our free community education initiative. These sessions are created to make information more accessible so that patients, caregivers, and the wider community can feel more informed, supported, and less alone. We believe that knowledge is power, and choosing to be enlightened empowers us to make informed decisions, ask better questions, and advocate for ourselves and the people we care about. And that is exactly why these quarterly sessions exist. So some housekeeping before we begin. First, please keep your microphone muted throughout the presentation to minimize background noise. Second, today's session will be recorded for E for Endometriosis Educational Archive and YouTube channel so that the community can revisit the session anytime they need a refresher and share it with others who may benefit from the information. Third, we will be using Pigeonhole Live for the Q&A segment later. So later on, you can scan the QR code that will be shown on the screen to submit your questions. You may submit your questions once you are able to access the QR code, and you may also upvote questions that resonate with you. We will try our best to address as many questions as we can during the Q&A segment. Lastly, please note that today's session is for general education and awareness only. It is not a substitute for personal medical advice. So if you have specific concerns about your symptoms, diagnosis, fertility, surgery, medication, hormones, or treatment options, please consult your doctor or healthcare professional. Our session today will run from 11:30 a.m. to 12:30 p.m. We will begin with a presentation by Dr. Steven Teo, followed by a Q&A segment using Pigeonhole Live. So now it is my pleasure to introduce our speaker for today, Dr. Steven Teo. Dr. Steven Teo is a consultant obstetrician and gynecologist at STO+G Practice. He is a fully accredited gynecologist who specializes in IVF and endometriosis. His passion lies in helping couples with fertility challenges, as well as women living with endometriosis. His specialist surgical training in Sydney, Australia, has led to him focusing on advanced laparoscopic surgery for endometriosis, ovarian cysts, and fibroids. For patients who require IVF, Dr. Steven Teo is experienced in tailoring treatment plans to achieve the best possible outcome for each woman. As no two patients are the same, Dr. Steven Teo's combination of subspecialty skills allows him to develop bespoke therapy plans for each patient while supporting them throughout their fertility and care journey. So today, Dr. Steven Teo will help us better understand endometriosis and its commonly coexisting conditions, why symptoms can be complex, and how patients can be better supported in making informed decisions about their care. So please join me in warmly welcoming Dr. Steven Teo. And Dr. Steven, over to you.
Thank you. Hi, very good afternoon to everyone who's here today. Thank you to E for Endometriosis for inviting me to this talk. The topic today is going to be about endometriosis and its associated comorbidities. Can I just double check, make sure that you all can see the slides?
Yes.
Okay, that's good. Now, I'll just start off with a bit of introduction about endometriosis itself. So endometriosis, as a lot of women will understand, that it's related to painful periods. But it's not just that. It is estimated that about every 10 women, one will be affected by endometriosis. And this is usually within the reproductive age group. Now, the endometrium is actually the inner lining of the womb. And this is a very specialized tissue that's programmed to grow and thicken in preparation for pregnancy. But if there's no pregnancy that occurs during that menstrual cycle, it will shed. So for the women in the reproductive age group, you should be getting regular menstrual cycles where you can see menstrual period, but you can feel the effects of the hormone that is orchestrating this whole cycle. Now, if you look at this image here, this is what we typically see of endometriosis, which are little pockets of endometrium that is located outside of the womb. So when you have endometrium that's present outside of the womb cavity, that's by definition endometriosis. And this deposits of endometrium outside of the womb is still sensitive to estrogen and progesterone, which is orchestrated by your reproductive cycle. And depending on where these pockets are located, the symptoms may vary quite widely. So for women who have got endometriosis, you may recognize these symptoms: regular period cramps, painful intercourse. You may experience pain when you pass motion. You can also experience pain when you empty your bladder. As the condition gets worse, your pelvic pain becomes chronic, constant, incessant, whether you're having period or not. For those who are interested, these are the medical terms for the corresponding symptoms. So you can imagine if you have these pockets on the back of the womb, near to the cervix, during penetrative intercourse, when you move that part of the body, it will be painful when you have sex. And if you have these pockets on the rectum, as you pass motion, it can be quite painful. Similarly, if you have these deposits on the bladder itself, as you empty your bladder, it can be quite uncomfortable as well. So why does endometriosis happen? To be very honest, we still don't know. There's a lot of research that's going on right now, trying to piece things together, but we still don't know what is the exact cause for endometriosis in a specific woman. There are a few leading theories that we are working on. It started off with the backflow of menstrual blood, which we term as retrograde menstruation. Through the fallopian tube, menstrual blood, instead of exiting the body, can flow back into the pelvis and get stuck there. And sometimes tissue that's in the pelvis may spontaneously change to become endometrium or endometrium-like. That's classified under metaplasia. And there's a theory that some of these endometrial tissue can be spread to distant parts of the body through the blood vessels or the lymphatics. And the most recent and most likely theory is that there might be a problem with your immune system or even a genetic predisposition that allows this condition to be to take place and be more severe than usual. So it's very likely that individual women have got very different combinations of these causes, either more than one of them or maybe a very unique one that's not in this list. As such, the appearance of endometriosis and the severity can vary quite widely between women who are affected by this condition. As a result, the types of coexisting medical conditions can differ quite widely as well. So what is comorbidity? For those who are not familiar with this term, it's basically just another medical condition that occurs alongside endometriosis, for example. Endometriosis is largely recognized and agreed to be driven by estrogen. That's why it's usually a disease of women in the reproductive age group. very seldom you see postmenopausal women being affected by active endometriosis. Endometriosis is a very aggressive inflammatory condition which causes a lot of tissue damage, which leads on to the symptoms that follows. And endometriosis might actually have a genetic root. Okay, let me summarize the comorbidities into a few groups. First, I'm going to talk about comorbidities of endometriosis that occur in the womb. Primarily, we're going to talk about adenomyosis, endometrial polyps, and endometrial fibroids. The common thing for these three conditions are that they are all fueled by the same hormone, which is estrogen. Now, if you look at this image, this is a pictorial representation of the womb with the two ovaries at the sides and the fallopian tubes. These are fibroids. These are endometrial polyps. And just now, the image of endometriosis that we saw just now, you can actually have little pockets of endometrium within the muscle wall of the womb, which is adenomyosis. The next group will be conditions that affect fertility. Very commonly, we see women with endometriosis having very depleted ovarian reserves. Sometimes we encounter women with both endometriosis as well as PCOS. PCOS is very recently renamed as PMOS. Early pregnancy failure is a very common encounter for women with endometriosis. I'll be going into more details later. Then comes the conditions that affect pregnancy itself. During pregnancy, if you have pre-existing endometriosis, you're more likely to experience increased or more exaggerated pain, more likely to have a low-lying placenta, more likely to have a baby that's not well grown, and the onset of preeclampsia is also more likely to happen. Preterm birth and stillbirth are also more likely to occur in women with endometriosis, but thankfully less common. Okay, now let me go through a bit of ovarian reserves and the impact of endometriosis. Now, for those who are not familiar, ovaries are the egg banks of women. You are born with all the eggs that you can have, and they are stored in the ovaries. Every month, you will be recruiting a batch, and one of them will mature to be ovulated. And this ovulated egg will get fertilized by sperm and get you a pregnancy. So if you start to have a depletion of your egg reserve, as it progresses, you'll find that it gets harder and harder to be pregnant. And finally, when you're down to your last eggs, you will be menopause. So endometriosis is well known to damage the ovaries in this way. Chocolate cysts that occur within the ovaries themselves are actually the most commonly seen form of endometriosis on scans. On the scan, you can see a big, well, the size may vary, but generally a chocolate-looking thing that's filling the inside of the ovary. And these cysts actually have got the greatest impact on ovarian reserve. However, we also know that endometriosis that do not directly affect the ovaries, for example, they may be on a surface nearby or on other structures that may be in contact with the ovaries, are also known to affect reserves in women. How do we pick this up, and what are the treatment options? A bedside ultrasound scan and certain blood tests will be the basic tools to assess how much eggs are left in the ovaries of a woman affected by endometriosis. The treatment options may vary quite widely. Not everybody is desiring a pregnancy. So for those who want to get pregnant, the treatment options will vary a little bit. But generally, the treatment fall into these three categories: either meticulous keyhole surgery to remove the disease, hormonal therapy, which is suppressive in nature to suppress the onset of endometriosis by reducing estrogen, or assisted reproduction via IVF. So these are the common ultrasound images that we see On the leftmost, this is what would a normal looking ovary will look like. You have a few of these black holes, which each of them being an egg follicle. And in the event that a woman has polycystic ovaries, where there's a lot of extra eggs, they may look like this, polycystic multiple eggs along the periphery of the ovary. And this is what a typical chocolate cyst will look like on the scan. Finally, if after years of damage has taken place, you can see that the ovaries are pretty much devoid of follicles. This is when the patient will be quite near to menopause. And this, surprisingly, can occur in a 30, 35, or 40-year-old lady. So treatment-wise, there is the three options that we speak of, but as always, prevention is better than cure. Because once you have depleted most of your eggs, there's no way treatment can replace them. So it is essentially a race against time. And by the time diagnosis is made, usually it's a few years, damage is already done. So to counter this, the preventive measure would be elective egg freezing. Yeah, so for women who are quite certain that they want to have children in future, this is a very good option to consider, because when you're young, you have a lot of good quality eggs. If you were to freeze them, you will not be held hostage by the fact that endometriosis may lead to a rapid decline of egg reserve when you are in the mid-30s, for example. Once frozen, these eggs can be kept for a very long time until you are ready to get pregnant. Should you fail to conceive naturally, you can tap on this pool of good quality eggs. Now, I'm going to talk a bit about early pregnancy failure. Basically, these are the two categories. Recurrent implantation failure, which is an IVF problem. You don't see this in natural pregnancy because you can't diagnose it. But every time we put in a good quality embryo and you don't get pregnant from it, you may have this issue of recurrent implantation failure. For those women who get pregnant and lose the pregnancy quite early, whether is it natural pregnancy or IVF, these are all under the category of early miscarriage. Sadly, for women with endometriosis, especially those with adenomyosis, they're more likely to have these two problems, which end up with early pregnancy failure. The exact cause is not fully established, but the logic states that it's most likely related to the degree of inflammation that's occurring in the womb and in the pelvis, as well as this theory of progesterone resistance. We know that endometriosis grows because of estrogen, and at the same time, they might be resistant to progesterone. Progesterone is actually a pro-pregnancy hormone, and it is a very useful group of hormones to use in the treatment of endometriosis itself. This group of comorbidities is actually very difficult and emotionally exhausting group to go through, especially if you are faced with a 4th, 5th, or 6th miscarriage in a row. It is a recognized condition and in certain cases quite treatable. So when it comes to early pregnancy failure and comorbidities that affect fertility, the treatment options can be classified into these 5 groups. First, as I mentioned earlier, progesterone-based kind of hormonal therapy is suppressive in nature. It can help suppress the growth of endometriosis. And it is particularly useful if you have intention to conceive, and just that it's not now, not yet. You have time to put in place this suppressive therapy. For women who are very much affected by pain and there are widespread disease, there's big volume chocolate cysts in the ovaries, then meticulous surgery can be undertaken to remove as much of the endometriosis as possible from the pelvis. For those faced with pregnancy failure, early miscarriage or implantation failure, progesterone remains the key tool that we will use. IVF, including egg freezing, are useful tools for women who are affected by endometriosis, especially when there is a depleted ovarian reserve. And for most of my patients, we need a combination of these modalities to tailor a regime that's suitable for your disease profile as well as your desired outcome. Now, I'm going to go through a little bit about how the conditions that are associated with endometriosis can make pregnancy a bit more complicated. Earlier on, I mentioned about the few conditions, and I'm going to go through a bit more details here. Increased pelvic pain. By right, early pregnancy shouldn't have pain, but I see a lot of my women, female patients with endometriosis experience quite an exaggerated amount of pain during the early pregnancy. This might be related to the chronic inflammation that they are experiencing in the pelvis. Very often, endometriosis is associated with scar tissue formation in the pelvis. The back of the womb is often stuck to the rectum and other surrounding structures. As the womb enlarges, it will pull along whatever that's stuck with it. So there's a lot of pulling pain that's experienced. And for women who have got adenomyosis, depending on how severe it is, the womb can be significantly larger than usual. And the amount of blood that flows into the adenomyotic womb can be much higher, leading to congestion and the feeling of aching pain. Now, this theory about low-lying placenta being more common in endometriosis, statistically, it's been proven. We just don't know why. There are a few possibilities, especially when there is adenomyosis. The shape of the womb may be unusual, may be distorted. The muscular movement of the womb may be abnormal. Now, you must remember that the womb, just like the heart, is made up entirely of muscles and the inner lining of endometrium. When the fertilized egg arrives into the womb, it will have to implant usually at the top part of the womb. And the muscular contractions, which is very subtle and very slow, is meant to guide this egg to the top part of the womb where implantation occurs. And if there's a lot of adenomyosis, the movement is abnormal, you may end up implanting lower in the womb cavity, which will set the stage for a low-lying placenta to occur later. And also, the formation of placenta, which occurs by about 10 to 12 weeks of pregnancy, may be affected by the amount of chronic inflammation present in the womb itself. Next, later part of pregnancy, women with severe endometriosis may actually suffer from these conditions, namely fetal growth restriction and preeclampsia. I put them together because I believe that their mechanisms are quite similar. First, it starts off with an abnormal placenta, which is most likely related to underlying adenomyosis. The blood supply from the mother to the womb and subsequently to the placenta may be affected by the chronic inflammation. And also there's probably an element of progesterone resistance that gives rise to all these as well. Now, if you can imagine a womb that is severely enlarged by adenomyosis, after delivery, it has to contract. But because it is filled with a lot of abnormal tissue, including adenomyosis, contraction of the womb after delivery may not be optimal. That can give rise to excessive bleeding after delivery. And throw in a low-lying placenta, that alone is going to increase the risk of post-delivery bleeding. Now, I'm going to talk a little bit about preterm birth. Premature delivery is often seen to be related to chronic inflammation. This chronic inflammation carries on from the pre-pregnancy state throughout into pregnancy, which can give rise to a spontaneous water bag leakage, which often leads on to either a spontaneous premature delivery or an induced labor because of fear of infection. And in women with severe adenomyosis, the womb is significantly larger than usual. That alone may trigger the onset of labor. Now, thankfully, stillbirth is not very common, but still statistically it's been linked to the presence of endometriosis as well. So a growth-restricted baby is less likely to have enough reserves. And if you were to go through any labor or a traumatic period, this baby is less likely to be able to withstand. Throw in the onset of preeclampsia, that alone increases the risk of stillbirth. Unfortunately, for stillbirth, the detection is usually quite difficult. And only if you are present in the hospital or in the clinic, and timely detection can save the baby. Otherwise, most of it is actually a post-event diagnosis. Okay, so this image illustrates how a normal womb can appear different from a womb that's affected by adenomyosis. So a normal womb should not have endometrium present in the muscle wall. As endometriosis progresses and adenomyosis sets in, you get little pockets of endometrium occurring in the womb muscle. And as it gets worse, the whole womb becomes distended with very unhealthy and inflamed tissue. So this ultrasound image shows you a part of the womb that is significantly distended. This is the muscle with adenomyosis, and the placenta is implanted over it. So when this occurs, the chance of this placenta being abnormal, not being able to supply or provide for the pregnancy, is higher. And you can imagine if this is at the lower part of the womb, the placenta is likely to stay at the lower part of the womb, leading to a low placenta. So this summarizes what we have just discussed. Women with endometriosis, specifically adenomyosis, they're more likely to have a growth-restricted baby at risk of stillbirth, a low-lying placenta, which increases the risk of bleeding, and the adenomyosis itself distorts the shape of the womb, can lead on to a malpresentation. Like in this case, if the baby's head's at the top, you won't be able to deliver safely. You will need a cesarean section. A very inflamed womb is more likely to end up with a premature contraction. And after delivery, the risk of excessive blood loss is increased. Now, preeclampsia is a very complex condition. I'm not going to go too much into detail, but just know that this, just like endometriosis, is still being studied. There's a lot that we don't know about preeclampsia. What we do know is it comes along with high blood pressure, protein leaking into your urine. You may start to have swelling of the legs that is more than usual. And preeclampsia is dangerous because it can become eclampsia. Eclampsia is a very serious condition where you get seizures, brain swelling, liver problem, and kidney problems. This occurs just before delivery, or when it does occur, delivery should be expedited. Okay, now I'm going to go into more details about adenomyosis, which essentially is endometriosis of the womb muscle. So you can imagine adenomyosis will share the same root cause as endometriosis, where the endometrium, instead of growing within the womb cavity, is extending into the muscle wall. After repeated cycles of endometrial tissue that's shedding into the muscle itself, you start to have a swollen muscle, an enlarged womb with chronic inflammation. This can result in severe pain, especially during menstruation, And in certain cases, when this adenomyosis grows beyond the muscle wall into the surrounding structures, for example, the rectum, then you can start to feel pain when you pass motion. Again, this is to demonstrate the presence of adenomyosis in the muscle wall. In a real life patient, this is what it will look like. An enlarged womb, and you can see the adenomyosis is actually growing through the muscle to the surface of the womb already. So what does it do to you? We spoke about its impact on pregnancy, but on a day-to-day basis, if you have adenomyosis, you may start to feel variable degree of menstrual cramps. This is variable because everybody's pain threshold is different. But for those who are affected, you may end up with affecting your school or work performance. You may start to have anemia from excessive menstruation. The amount of clots and overflow that you get every month will be much more than usual. For women where the adenomyosis is so severe that the whole womb is very big, that alone will assert a mass effect on the surrounding structures. For example, rectum. If you have a very big womb, you may have difficulty passing motion because it's pressing on the rectum. And for more severe cases, it might even press on the urinary tract. I will show you a photo of that later. And of course, for those who are unable to conceive, it might be due to the recurrent implantation failure because of the chronic inflammation. So we've gone through the impact on pregnancy earlier. Now, diagnosis, depending on how severe the condition, very mild ones may be missed even on a bedside ultrasound. And sometimes these symptoms are mistaken as normal. For example, a lot of my patients think that menstruation is meant to be painful, which is not. Menstruation is a normal physiological bodily function. So there's no function in the body that's meant to be painful. Menstruation should not be painful. So if you actually have very painful menstruation, that could be a sign of something going on in the pelvis. So a very thorough interview with a bedside ultrasound and a pelvic examination will often be able to clinch the diagnosis. More challenging cases, especially those with very significantly enlarged womb, may benefit from an MRI scan, especially when there are other forms of endometriosis. For example, those that involve the ovaries, chocolate cysts, and those that that involves the rectum. So the MRI will be a good tool to evaluate the rectum. Okay, so on the ultrasound, this is what a typical womb will look like. Slim, elongated, and the star is the top of the womb. So the top of the womb is supposed to face the same direction as the bladder. Similarly, this is a womb that is curved in the correct direction, the top of the womb facing the bladder. A womb with adenomyosis will look a lot bigger, almost round in certain cases, and the top of the womb is actually flipped towards the back, away from the bladder. And you may see a significantly thickened either posterior wall or anterior wall. Most often we see it at the posterior wall because that's where it starts to grow beyond the boundaries of the womb and may even start to attach itself to the rectum behind. Yeah. In certain cases, we actually see little cysts of blood within the adenomyosis itself. That tells us that this is a severe case of adenomyosis. And very often, these are the source of pain when menstruation occurs. Treatment must be individualized to the woman. And that takes into account what are the desired outcomes of treatment. And based on the disease itself, is it a diffuse adenomyosis where the whole womb is involved? Or is it a specific area only, just like a fibroid? For women who are amenable to hormonal suppression, that's actually an effective form of treatment. It basically reduces your estrogen production and increases certain groups of progesterone that will target endometriosis tissue. But as you can imagine, that will not be suitable if you're trying to conceive. Surgically resecting the endometriosis or ablating the endometriosis or even removing part of the adenomyosis is possible, but you always have to balance it against the scar that it leaves, especially if you try to resect a part of the muscle wall of the womb. That essentially may weaken the womb, and if you do get pregnant, there's always a small chance that this scar may give way. In certain cases where the diagnosis has been delayed significant enough, the womb has been given time to grow to a very enlarged size, sometimes it cannot be reversed even with hormonal treatment. And quite often, hysterectomy is the end point for this group of patients. So timing is critical. Timing of diagnosis is important. The earlier you diagnose it, the more options you have available to tackle this problem. And timing is also critical in terms of treating for pregnancy. For example, if you are actively trying to conceive, but you want to resect the adenomyosis, you need to give time for the wound to heal. Minimum 6 months, sometimes even up to a year. Hormonal therapy, unlike surgery, takes a bit longer to be effective. Taking these hormones may give you the side effects early, but the benefits come on a bit later. So typically, you will start to experience the pain improving maybe after 4 to 6 months, and you may require hormonal treatment for up to 2 years or more. Yeah, so I already spoke about the risks and benefits of surgery. As far as possible, unless the adenomyosis is very severe, I usually will stay away from surgery with regards to adenomyosis. Now, the next group of conditions are polyps. Now, polyps are actually grape-like growth originating from the endometrium. Yeah, so if you remember the image I showed you just now, they look like little skin tags that originate from the womb lining. Most of them are benign. Quite rare do we see polyps that are cancerous, especially in the reproductive age group. But this risk starts to increase when you get into the 40s and maybe closer to 50s. Just like the rest of the native womb lining, polyps are sensitive to estrogen, and they will grow when estrogen increases. So if you scan the same polyp throughout from the start of menstruation to the end, you will see that they tend to grow bigger towards the end, and then as menstruation occurs, as the lining sheds, the polyp itself also gets smaller. The presence of polyps may give you problems with abnormal bleeding. You may have very heavy menstruation. You may have spotting before your actual menstruation starts. You may have spotting when the period has already stopped. Or you can get spotting in the middle of the cycle, for example, after sexual intercourse. The other major impact of endometrial polyp is it gets in the way of implantation. You can imagine if you have multiple or large polyps that occupy the space of where the pregnancy is supposed to occur, then implantation is less likely to occur. And then the last concern is that even though they're mostly benign, there is once in a while a chance that it can be cancerous. So this image shows you where an endometrial polyp will occur, which is within this triangular cavity. On the scan, you may see this grape being sandwiched between two slices of bread. Yeah, so the polyp sits exactly where a pregnancy will be. And if you were to put a scope, a small camera into the womb, you will see this is how a polyp will look like. Of course, this is a typical appearance of polyp, and some of them may be a bit flatter, some of them may be occurring in folds. And when you have multiple polyps, on the scan, you may see like teeth growing within the womb cavity. And on the scope, you can see all these multiple polyps. It gets a bit more concerning when it starts to look very disorganized, and in certain cases appear like a fungating growth or very increased blood supply. These are all signs of possible cancer. So how do we diagnose endometrial polyps? It starts off with an interview. Sometimes just by asking for any abnormal bleeding patterns, the suspicion is raised. And this is confirmed by ultrasound that can detect certain polyps, especially the big ones. Specifically for endometrial polyps, the powerful CT scan and MRI are actually not so useful here. I find that ultrasound, being a more dynamic test, tends to pick up the smaller polyps better. Once we suspect that a patient has endometrial polyp, then we can talk about endoscopy, which is basically putting a small camera into the womb so that we can see the polyp itself. And at the same time, we can remove. When we remove the polyps, we will usually also biopsy the surrounding womb lining just to make sure that there isn't precancerous or cancerous change near to the polyp itself. This is a very minor surgery. Most of the time it's done as a day surgery, but the patient can go home a few hours later. Most of my patients will choose to do it under anesthesia, even though sometimes you can do it without anesthesia. And whatever tissue that we harvest from the endoscopy will be sent to the lab for microscopic examination, just to make sure that there isn't a spot of cancer or precancer, both of which will need treatment. Now, the other problem with endometrial polyp is they often recur. You can remove a polyp now and the patient can grow a new one a couple of months down the road. So because of that, regular follow-up is actually recommended. For women who have no intention to conceive, then certain hormonal treatment can reduce the chance of polyps growing back. For example, the Mirena, which is an IUCD with hormone on the stem, can be used for up to 5 years. And as the hormone leaks out to affect the womb lining, it also reduces the chance of polyps growing again. Rarely, if there's precancer or frank cancer that's detected, then treatment is compulsory. It can be in the form of hormonal treatment or in certain cases, even removal of the womb. Okay, now, uterine fibroids. This is probably something that all women would have heard of. The formal name is leiomyoma. This is a very common benign tumor that arises from the muscle of the womb. Earlier on, we spoke about adenomyosis, where endometrium invades into the muscle wall. In uterine fibroids, the tumor originates from the muscle wall itself. And similar to polyps, endometriosis, adenomyosis, growth of fibroids are actually stimulated by estrogen as well. Now, the location and the size of the fibroid will determine its impact. So in this image here, you can see a fibroid can start growing from within the muscle. As it gets bigger, it can usually indent on the outside of the womb, which is better than indenting on the inside of the womb. Because when you indent on the womb lining, this is going to cause excessive AV menstruation. It's going to be in the way of pregnancy. Now, the best fibroid, if you can choose, will be one that is hanging on the outside by a thin stalk. This usually will not affect the woman much. Yeah, so how can these fibroids affect you? You can have no symptoms at all, or depending on whether they affect the womb cavity, you can experience very heavy menstruation. They can distort the womb to cause problems for implantation and pregnancy. And although these fibroids on the outside tend not to cause too much problem, as they grow very big, you can imagine them pressing on the surrounding structures. Now, fibroids are very rarely cancerous, but if ever a fibroid has to be taken out, it is also sent for microscopic examination to rule that out. Fibroids are very easily detected on ultrasound and a pelvic examination, but it's the location that matters the most. So ultrasound is very good at locating fibroids and determining whether they require attention and treatment or not. Occasionally, if a fibroid grows very big very quickly, we are concerned about the possibility of malignant change. That means cancer. In these cases, we often will talk about either MRI or CT scan to evaluate for features of cancer in these fibroids. Now, there's no other way to treat a fibroid other than to remove it. So the main challenge is to select the correct patient for treatment. Not every fibroid needs to be removed, especially those that don't cause any symptoms. The next challenge is how to remove the fibroid. Now you can see on this ultrasound, this is the normal shape of the womb, and there's a big fibroid that's growing out of the boundary of the womb. You can imagine this fibroid not causing much heavy bleeding because it doesn't seem to be affecting the womb lining. But sometimes it can be so big that it compresses on surrounding structures. Fibroids per se usually doesn't cause pain because unlike adenomyosis, it is not inflammatory in nature. It's basically just a muscle that doesn't do anything except to occupy space. But space is limited in the pelvis, and if the fibroid does get big enough, something else will have to be compressed. So you don't need to have a very big fibroid to cause problem. In this case, a fibroid that is strategically located within the womb cavity itself is going to cause a lot of symptoms, especially with abnormal bleeding. In this case here, this fibroid sits entirely in the womb cavity, so it increases the surface area for bleeding. And because the fibroid itself is abnormal, after menstruation, the blood vessels do not really constrict properly. So you can have prolonged and heavy menstruation in this case. And this is not a very big fibroid. It's actually quite a small one, maybe about 1 to 2 centimeters. Now, the difference between adenomyosis and uterine fibroids are adenomyosis tends to be a bit more diffuse. The walls, you don't really know where it starts or ends. The whole womb can be enlarged versus a discrete muscle tumor, which is a fibroid. And treatment is very different because this is less likely to be inflammatory. This one, you don't need to have a very markedly enlarged womb to have a lot of symptoms. Okay, so if treatment is needed, it is usually by surgical removal, which is called myomectomy. Very occasionally, we will talk about melting or burning it during the surgery, depending on where it is. And most of the cases that are done nowadays are done through a keyhole surgery or sometimes even without a hole. It just goes through the vagina. This is only for fibroids that exist within the womb cavity itself. Whichever route you take, well, the tissue that is removed must be sent to the lab for examination. So in this case, you can see this is within the womb cavity. This camera is sitting in the womb cavity itself. I can see this big, well, it's not very big, this fibroid that's occupying the entire womb cavity. This woman will be experiencing very heavy menstrual bleeding, and treatment will be just to shave this off in pieces. So there is this electrosurgical loop that we use to cut off the fibroid, and the pieces of tissue will be sent for examination. Remember, I mentioned that the best fibroid will be those that are growing outside the womb with a thin stalk. This is probably one of them. This may only be detected during surgery because they may not cause much symptoms unless it grows big enough to compress on the rectum. And if you have a fibroid that's big enough, it will have some mass effect. Okay, so this image is showing how the usual urinary tract runs. The white color bits will show the course of the ureters. In the event that you have a big pelvic tumor, it can be a benign fibroid, but if it's big enough, it's going to cause pressure and backflow or swelling of the ureter. This can lead on to kidney failure. Okay, well, cancer is very rare in the reproductive age group. Endometriosis itself is not cancerous, but because of the inflammatory nature of endometriosis, women who are affected by endometriosis has up to 4 to 10 times increased risk of cancer occurring. And this is usually in the setting of very severe endometriosis. We still don't know why it comes on, but it is most likely related to inflammation, excessive estrogen being produced. There might be a genetic link or immune issue that predisposes the onset of both conditions, endometriosis as well as aggressive cancer. As for most conditions, early detection will make more options available. Reducing inflammation logically should reduce the chance of this condition, but it's not been proven yet. And regular monitoring is actually a good tool to consider. So for severe endometriosis, you get both ovaries stuck to the womb. There's a lot of damage to the tissue. There's a lot of cellular turnover. It's this cellular turnover that increases the chance of one of these cells actually becoming cancerous. And this is an image of a chocolate cyst being drained. Now, next, we're going to talk about PCOS, previously known as PCOS. Now it's polyendocrine metabolic ovarian syndrome. Well, traditionally, it was thought to be a fertility condition only, but we've realized that it's actually a whole body metabolic condition that will affect more than just the fertility hormone system. So in terms of fertility, it will disrupt your regular menstrual cycles. It causes a higher than normal level of male hormones. And the typical appearance is a polycystic ovary on scan. That's why in the old name, it was known as polycystic ovarian syndrome. Outside of fertility, it carries a lifelong metabolic risk, which includes diabetes, high cholesterol, high blood pressure, and as a result, the risk of cardiovascular events happening is higher. So on the scan, this is what a typical polycystic ovary will look like. And although it's not very common, we do see some women experiencing hirsutism, increased male pattern of body hair. Yeah, so a typical PCOS or PMOS will be affected by central obesity, insulin resistance leading to diabetes, multiple cysts in the ovaries with lack of ovulation and hence infertility. The increase in testosterone will increase the risk of cardiovascular heart diseases. And there might even be non-fertility manifestations like increased body hair or acne. Now, this association between PMOS, PCOS, and endometriosis is actually a surprising finding because for the longest time, they were thought to be opposites. One is causing the woman to have an excess number of eggs, whereas the other is prone to depletion. But during my practice over the past few years, I've found that actually it occurs quite frequently in the same woman. So much so that certain studies have quoted 1 in every 4 women with endometriosis may have PCOS, and Correspondingly, women with PCOS, about 3/4 of them may actually have endometriosis at the same time. Why is that so? It again is still being researched on, but we are probably looking at genetic predisposition, a dysfunctional immune system, and probably a dominance of estrogen production in the body. Now, having both PCOS and endometriosis at the same time just means that the treatment is going to be more complicated. And usually this is resulting from a delayed diagnosis. Quite often, PCOS is easy to diagnose, and you might be distracted by that diagnosis until endometriosis gets so severe that symptoms starts to arise. And then finally, after 5 to 7 years, you come to the diagnosis of endometriosis. So you can actually have endometriosis sticking the rectum to the womb with a concurrent polycystic ovary. This image shows ovarian drilling as one of the treatment options for PCOS. Now, managing PMOS, the key categories would be to optimize weight, screening for diabetes, because this is a lifelong condition, and it's important to control it properly for quality of life. And in terms of fertility, usually we can't run away from ovulation induction, where medications are used to induce ovulation so that fertility can be restored. In certain cases, ovarian drilling can be considered because the polycystic ovaries may be very resistant to hormonal treatment. Or especially when there's endometriosis that's already been planned, you can at the same time address the issue of PCOS. So when both conditions coexist, then treatment has to be tailored to address both. Now, we also see women with endometriosis having other non-pelvic conditions. For example, autoimmune diseases, SLE, thyroid problems, or even rheumatoid arthritis are more common in women with endometriosis. Inflammatory diseases like IBS, inflammatory bowel disease, these actually have a lot of overlap in terms of clinical presentation with endometriosis. Quite a lot of patients who have been labeled as having irritable bowel syndrome actually have endometriosis. And if you treat the endometriosis, the bowel problems actually improve. Next group will be the pain syndromes, neuroinflammation, where pain that is nerve related, and this can occur anywhere outside of the pelvis. And complex pain syndromes can occur in women with endometriosis, for example, fibromyalgia, chronic fatigue, headaches, etc. And last but not least, being such a dreaded disease, the pain, the infertility, and the possibility of recurrence are tremendous stress for the mind, such that a lot of women with endometriosis actually experience anxiety, depression, and some even consider self-harm. So this is actually a very real physical and emotional condition. So mental health support is actually key for this group of patients. Yeah, so for women with endometriosis, if you find that it's actually quite hard to cope with the symptoms, you should seek help because there are options available for you. Okay, so to summarize, I'm just going to give you these 4 points to take back. Endometriosis seldom comes alone. It is part of a family of related hormone-driven and inflammatory conditions. The same process that causes pain can also affect fertility and pregnancy itself. And there are options to manage or risk manage these. Early diagnosis is important. Likewise, if the diagnosis is delayed, often it reaches a point where it's beyond repair. A very severely adenomyotic womb may end up having a hysterectomy. If your ovarian reserves are depleted, then you may not be able to conceive naturally. You may need to consider IVF. Persistent pelvic pain, heavy periods, unable to conceive after trying for a year or two are always good reasons to get yourself checked out for. Because if you wait long enough, like I said, it might not be amenable to treatment after that. Okay, I've reached the end of this presentation. If you have any questions relating to the points that we have raised, feel free to voice up. Or if you do need to get more personal kind of input, you can reach me at this email.
Okay, thank you so much, Dr. Steven, for that very insightful and clear sharing. I think for many of us, this topic can feel overwhelming because it touches so many parts of our life, not just the pelvis, but also pain, fatigue, digestion, mental well-being, fertility, daily functioning, and quality of life. So thank you for helping us understand this with such clarity and care. And since it's past 12:30, I just wanted to check with you, Dr. Steven, if it's
Yep.
okay, if we can extend the session a bit by 10-15 minutes
No
for
problem.
Q&A.
It's okay.
Okay. Thank you.
Do you have any questions from the audience? Because I don't think I can see.
Yeah, Namira will be showing some questions from the Pigeonhole.
Okay, so I will stop screen sharing.
Okay, thank you. Yep, so we will be moving on to our Q&A. If any of you have yet to submit your questions, please scan the QR code and submit your questions there. And a gentle reminder, today's Q&A is meant for general education awareness. Any personalized medical advice that you need, please contact your doctor or healthcare provider. We won't be able to provide personal medical advice or comment on individual cases in detail today. So I'll just move directly onto the question that we have on screen. Can be very confusing to know whether every symptom is caused by endometriosis, and when should severe fatigue, bloating, bowel changes, urinary problems, headaches, or widespread body pain be investigated as a separate or coexisting condition? This is a very popular question with 8 upvotes. I think many of us relate to it. So, Dr. Steven,
Yeah.
over to you.
So now, as a general rule, if you have one condition that will explain all your different symptoms, then that's more likely to be the cause compared to you having bowel problems, urinary problems, or any other pelvic conditions causing one problem each. So if you actually have the symptoms that we discussed just now, it's actually worth seeing a doctor to get that sorted out, because a detailed pelvic examination plus a scan, the bedside scan, is going to give us the diagnosis for about maybe 70-80% of the time. Sometimes after examining, we realize that there isn't really that much endometriosis, or we don't detect signs of endometriosis. Then that's where we will need to refer to either colorectal specialist or urologist for further evaluation.
Thank you. That was very helpful. Moving on to the next question. Yeah. The next question is, I've heard of cases where people have lesions on their brain and lungs, and it affects them every time of the month. When do doctors go to the extent of looking at other parts of the body, other than the abdomen area, and how can it be detected? Thank you
Okay,
for
so
this.
first thing is you cannot shut your mind off from the fact that endometriosis can spread out the pelvis. Although it's not very common, but if you have symptoms that only occur during menstruation, then that's an alarm bell. Because I have got a patient who has endometriosis. We know she has endometriosis. She has got cysts, chocolate cysts in the ovaries. But the strange thing is, every time towards day 2 or 3 of her menstruation, she starts to have a pneumothorax. That means her lung bursts and she gets air leaking out from the lung. And she gets it quite often. Finally, we did an MRI and we found that there was actually a small spot of endometriosis on her lung itself, which every month when you have menstruation, it also bleeds. And that results in her symptoms of pneumothorax. Not very common, but if you have symptoms that are only restricted to certain parts of your menstrual cycle, then that might be a clue to tell you that it might be related to estrogen, progesterone, and the commonly missed diagnosis will be endometriosis. I've yet to see one that's gone to the brain, but we have seen quite commonly endometriosis occurring on the rectum, some along the urinary tract, in the lungs. We've had patients with nerves being affected. Yeah. And certain individuals who have had surgery done before, sometimes you get implants of endometriosis on the surgical scar itself. That's actually not too uncommon.
Thank you for that. The next question we are looking at is, some patients continue to experience pain and other symptoms even after surgery or hormonal treatment. So, like, why does this happen? Could it be related to remaining disease or nerve involvement, pelvic floor dysfunction, changes in pain processing, or another undiagnosed condition?
Yeah, okay. So this is actually a pretty common problem that is quite hard to manage because pain, the end point of pain may be due to a whole variety of contributing factors. Certainly, the condition itself can cause pain. If the condition has been treated, the neural inflammation, the inflamed nerves, can still lead you to experience painful conditions. The psychological scarring that you experience from the pre-treated, from the endometriosis before treatment may still linger in the background. Sometimes, for example, if you have painful intercourse, even after the endometriosis has been removed, even after the scarring has been removed, you may still feel the pain of intercourse because of the fear of it. So it's a very complex function. You will probably need to evaluate this symptom very carefully, and quite often a multidisciplinary approach may be required. And quite often a psychologist may be useful to be on board. Yeah, and if you are quite comfortable with the fact that endometriosis is pretty much eradicated with surgery and hormones, then the other conditions such as neuroinflammation comes into play. There are specific treatment for that, which we will refer to the neurologist.
Thank you. That was very helpful. Okay, so many of us seem to have more than endometriosis alone, which was largely what today's session was about. And this question is, why are people with endometriosis more likely to experience other health conditions? Are there shared biological causes, or can years of inflammation, chronic pain, and delayed diagnosis contribute to these comorbidities?
Okay, so first of all, the point that I need to drive home is it is not something that you did. Okay, it's not something that you did that give rise to all these. As I mentioned, the common pathways could be a genetically predisposed individual, impairment in your immune system, because the immune system does a lot for us. It can survey there's surveillance all around the body to look for cancer cells, to look for endometriosis cells. And if you are healthy, you should be able to get rid of these. So if you have an immune defect, then that gives rise to a lot of possible problems, especially those that relate to inflammation. Then the dominance of estrogen is a big factor. especially for conditions that are driven by estrogen, like the endometrial polyps, fibroids, endometriosis, adenomyosis. Progesterone resistance is another consideration. For example, if you have PCOS, you don't ovulate. Without ovulation, you don't produce your own progesterone. That means the whole body is constantly being stimulated by estrogen without any opposition. Yeah, so there are many possible reasons. We still don't know what are the reasons that affect the individual. You can have various permutations of these, or none. You may have something else that is yet to be recognized. But it's certainly not something that you ate or you did that causes it.
I think that's a very important takeaway for us. A lot of us do get into a cycle of self-blame sometimes. So thank you. Moving on to the next question. Some patients also live with allergies, hives, digestive issues, or symptoms that seem to flare at certain times of the month. So if endometriosis actively involves hormones, inflammation, and changes in immune activity, then what role might mast cells and histamine play?
Okay, that falls under the realm of immunology, which I'm no expert in. But if you are talking about symptoms that fluctuate with the hormonal fluctuation, then what you can do as a test or as a treatment would be to remove that fluctuation. In the body, you will naturally have increase in estrogen, leading to womb lining thickening, and then after that, ovulation and progesterone production. If you can remove that cycle totally, then you may be able to see an improvement in your symptoms. For example, hives that only occur during menstruation. So you can test it out by taking the injection that sort of makes you menopause temporarily. The injection can last anywhere between 1 month to 3 months. And during this period of time, if you find that there is a significant improvement, then it sort of tells you that it is something that is related to hormones. And in the long term, you can plan to see how you can tackle this issue. But if you have taken the injection, you're in a hormonally uniform state, there's no more fluctuation, and yet the symptoms still persist, then it might not be something that's related to your hormonal fluctuations. Yeah, so it's not an easy thing to dissect. A lot of times it's quite a bit of trial and error.
Right. Thank you. Maybe a few last questions. Many of us still struggle to understand what endometriosis actually is. Is it primarily an inflammatory disease, a hormone responsive condition, an immune system disorder, or a combination of all three?
It is most likely a combination of all three. It is hormonally driven. It is an inflammatory condition. And being an inflammatory condition, it comes along with a lot of tissue turnover, scarring, damage, distortion of the normal anatomy. Yeah, so it is a complex condition that is driven by a few key pathways.
Okay, thank you. So, that was our last question. So, thank you, Dr. Steven, for answering these questions with so much care. And before we close, may I invite you to share any final thoughts or key takeaways for our community today?
Yeah, thank you very much for having me today. I think if there's only one thing that I can share with the audience, that would be don't ignore the pain that you feel, because biologically, menstruation and all these normal bodily functions are not meant to be painful. So pain is probably your first and most important signal that something is not right. You should seek medical attention as early as you can, because the worst case is there's nothing wrong with you. Then you are reassured. But if there is something wrong, then you catch it early, treatment is usually more effective.
Thank you so much. That was a very meaningful reminder for all of us. So we may not be able to go through every question today, but we hope this discussion has given everyone a clear starting point. We will now move on to our closing segment. So thank you so much again, Dr. Steven Teo, for your time, knowledge, and generosity in holding this space with us today. And thank you to everyone who joined us live, submitted questions, listened, and chose to spend your Saturday learning with us. So today's topic is not always easy to talk about. Endometriosis itself is already very complex, and when other coexisting conditions come into the picture, can become even more confusing, exhausting, and difficult to explain. But conversations like this help us bring light into areas that many have had to navigate quietly for far too long. At E for Endometriosis, we believe that education should be accessible. We also believe that people deserve to understand their bodies, their options, and their care journey with more clarity and confidence. So this session will be made available on our YouTube channel. So please feel free to revisit it whenever you need a refresher and share it with someone who might benefit from this knowledge, because knowledge is power. And when we choose to be enlightened, we empower informed decisions. And with that, we would like to announce our next quarterly Zoom session, for which registration is now open. So we warmly invite you to join us again in September as we hear from Dr. Gurpreet Kaur, a fellow endometriosis advocate, TEDx speaker, and member of our wider community. Her session will bring a lived experience and advocacy perspective into the conversation, reminding us that education is not only about medical knowledge, but also about understanding the human side of living with endometriosis, the realities patients carry, and the importance of community voices in shaping awareness and change. So you may register through the E for Endometriosis Eventbrite page, and you may also visit our website at www.endosupport.sg or follow us on Instagram, TikTok, and Facebook at E for Endometriosis for the latest updates. And we hope to see many of you again at our next session. And once again, thank you so much, Dr. Steven Teo, and thank you everyone for being here with us today. Take care, and we hope to see you again at our next quarterly Zoom session. Have a lovely Saturday, everyone.
Thank you. Bye.